Thank you for joining us for this special presentation. We've assembled an exclusive panel of global experts driving the development of artificial intelligence to discuss AI's profound impact on healthcare, especially as it relates to the work of federally qualified health centers and those concerned about the care of special populations. Almost by the minute, AI is reshaping diagnostics, treatment, and patient care, transforming the very fabric of our healthcare landscape. As we explore AI's potential, we must not forget that our true quest is not merely technological advancement, but the creation of a healthier, more equitable world for all. We must also acknowledge the profound concerns AI raises. The path ahead is riddled with challenges, including issues of equity, privacy, and ethics. How do we ensure that AI benefits everyone regardless of their background or socioeconomic status? How can we safeguard patient data from breaches and misuse? What ethical dilemmas might arise as we entrust AI with critical healthcare decisions? Dr. April Joy Damian, the Vice President and Director of our Weitzman Institute, will address these issues head-on with our three esteemed panelists, to whom we extend our heartfelt gratitude for sharing their precious time and expertise, and to our audience, thank you for joining us on this exhilarating journey. Please continue to follow the Weitzman Institute for more educational programs on this topic, including a national webinar addressing AI and health equity at the end of October.
Hello, and welcome to a special conversation on artificial intelligence in healthcare. We are so glad to have you join us. I'm Dr. April Joy Damian, Vice President and Director of the Weitzman Institute, based in Washington, D.C. At Weitzman, our mission is to promote equity and optimize health outcomes for vulnerable populations through innovative research, education, and policy. Like many of you watching this broadcast, our researchers at Weitzman are exploring ways that AI can advance and improve care for the populations we serve. Similarly, our education and policy staff are focused on ensuring that the primary care workforce is able to keep up with the rapidly changing field. We are very pleased to be joined by a panel of leading experts at the forefront of AI. Anish Chopra, President of CareJourney and the first Chief Technology Officer of the United States under the Obama administration. Dr. William Weeks, a physician economist leading Microsoft's AI for Health program, and Dr. Roland Iling, the Director and Chief Medical Officer, International Public Sector for Amazon Web Services. We hope you will come away from this conversation with more knowledge and heightened curiosity about what this evolving technology could mean for healthcare delivery.
Please welcome our first expert, Anish Chopra. Anish was selected as the first Chief Technology Officer of the United States by President Obama, responsible for promoting innovation, transparency, and collaboration within the federal government. Anish has been credited with rapidly accelerating the nation's technology agenda. His public service is focused on making public and private sector organizations more effective and efficient, as discussed in his book, Innovative State: How New Technologies Can Transform Government. He currently serves as president of CareJourney, a healthcare analytics company.
So we'll kick it off with our first question. So artificial intelligence is an emerging technology many are still trying to understand. How do you define AI?
Oh, that's a great question. So I try to keep it pragmatic. And to me, it's the set of technologies that allow for accurate predictions of the next best action. So in the case of what we think of today as generative AI, it's the capacity to predict the next word in a sentence that can answer a pretty important question, those that are important to you and me. That capacity of extracting from historical information a prediction about the future is what gives us such excitement around AI, because we don't quite know exactly how it does what it does. But what we know is that if the technologies are capable of performing this function, it has implications for healthcare, the environment, and a whole range of sectors that desperately need new solutions to solve very challenging issues that we just haven't quite figured out an alternative way to solve for just yet.
Great. Thanks, Anish. That was a very simplified and accessible definition of AI. It's often hard to understand. So next question. So AI is becoming indispensable to a myriad of industries and occupations. How are you seeing it being used to its best advantage, specifically in healthcare?
Well, let me begin by stating the obvious. It's just getting started. So anyone that sort of pretends to say, oh, here are the top 10 things that have absolutely happened in full scale, let me remind our audience, the world effectively changed November 30th, 2022. We're recording this not even a year since that launch. And what I'm referring to is the launch of ChatGPT, the user experience that allowed all of us to understand firsthand what this technology is capable of. It's been in the 50 years of computing history, it's been the holy grail. When will we have AI? What's the Turing test? When will we not know the difference between interacting with a machine and interacting with a human? How do we think about artificial general intelligence, where it has the capacity to empathize and understand and take actions on prompts that we might offer it? These are all science fiction dreams. And as I allude, we've had AI springs, moments of excitement, and we've had AI winters where there's been like, okay, people, this is, you call it AI, but it's not really, it's an if-then logic statement in Excel. Like, come on, people, this is not that complicated. We're entering a period of a spring, in my view, and it's largely explained by the large language models. Let me begin by saying we've had, in the last 5 years, dedicated, focused efforts to see the broader AI prediction technologies be applied in healthcare. Google owns a division called DeepMind, and it had a pretty significant impact on this journey. Google, of course, in general, was the one that released a paper that explains this thing called the transformer model, which is the sort of approach technically that allows a machine to consume vast amounts of data in order to compute the most likely next sentence or statement or word to fulfill an answer. How these large language models operate, how those transformers work, still not exactly clear. We're sort of understanding that it just does. And we're trying to figure out why and how. So there have been efforts over the last 5 years to apply this prediction engine to healthcare. And it's early to show the results, but we've seen some promising areas. One, imaging. Computers are able to read the same images that humans can read, and they're able to identify earlier evidence of cancer. That's a pretty powerful concept. And you might ask the question, should every image that's taken have an AI read, at least as a secondary eye, a set of eyes to the image? That's an important, relatively a repeatable use case. The second area is that we're beginning to find disease progression algorithms, that you can take a look at someone's health trajectory, and you might have a little bit higher probability of forecasting the next potential area where that patient's health may go. And knowing that early enough might facilitate interventions that could prolong people's lives. Those are the areas that I feel like have already come out of the gate strong. We're going to start to see a lot of examples that are the next wave of use cases. powered by these large language models that, for example, allow a recording of this call that you and I are doing right now, if we were to get a bit more clinical in our conversation, to translate that dialogue into diagnosis codes, into hyperlinks, literature, to see whether or not the condition that I may have has any clinical trials underway or other attributes, so that the verbal dialogue can become a computable asset. These are all really exciting use cases. And I guess last but not least, given that what I do for a living is analyze data, one of the more promising use cases is to train an AI model how to write the queries to answer the questions that you and I might have. So those are the areas that I'm excited about. I wouldn't declare victory on many of them. I would describe them as hypotheses worthy of testing.
So as you know, health equity is central to the work that we do at the Weitzman Institute. And many of those in our audience work within health centers caring for marginalized patients and communities. Do you have concerns about AI solutions when applied to diverse and underserved populations, both in the context of healthcare or more broadly?
I have lots of concerns about lots of things. I would say, let me begin. My highest and most important concern is that the patients in our most underserved populations tend to not have the access and the trajectory of what a best-in-class patient experience looks like. So the disparities that we've seen post-pandemic are acute in the very populations that your audience treats every day. And so at the highest levels, if I were to kind of, describe the upside and the downside, I will certainly highlight the downside, but I see a lot more upside than I would otherwise, because we're not going to solve for doubling the budget for HRSA clinics, doubling the capacity to deal with the uninsured beyond what we're able to do with the ACA. We've got gaps that are not sure how we're going to address, but for a leapfrog capability that may not break the bank. So let's just say the bull case to me is more focused than the bear case. Now, having said that, the bear case has a lot more to do with the reflection of the current data sets that are used to train. So we went a decade ago with not a lot of digitization in health. We've spent this decade funding the digitization, and what we're realizing is that the digitization is not reflective of what we want the society to look like. We're demonstrating that when we allocate care management resources, we tend to over-index for wealthier and healthier people, relatively speaking. Or even more uncomfortably, when we move organizations to value-based care, contracting models, while if you were to say to me, what's the highest and best use case of value-based care? It's the duals population. It's the underserved, complex, chronically ill patient. And unfortunately, the concentration of those patients tend to be in practices that are not currently enrolled. So when you kind of look at the matrix of highest and best use of a care coordination model, and then align that to who's currently enrolled in these models, you'll find a disconnect. Not sharp, and I don't want to say it's black and white, but on the margin, more of the enrollments take place in healthier, wealthier communities, more white, white and wealthy zip code. The underserved populations tend to be, I think duals are probably the lowest enrollment rate in MSSP ACO as a share of their population, to be frank. Now, given all of that, you asked me the question, are there biases in that data that an algorithm trained on the data may exacerbate? If it believes that we should be under investing in care management because historically we've not been investing there, and it propagates that bias by saying, who should be the next in line for this care management resource? Well, based on history, it's probably going to look like this healthier, wealthier white person. That's an extreme statement, but just doesn't matter at a higher level. That's a bit about what the researchers in AI who've been attacking models most notably the United Optum model that was built on dollars spent and not, taking other factors into consideration. That propagation of bias is something to be mindful. The great news is you can apply these very tools to help predict where might there be evidence of call them care gaps. And so you could actually train a model to actively counterweight that natural bias and say, by the way, you're about to allocate resources and it may be furthering the inequity. You might want to rethink about how you allocate your staff time. So we might actually find if we put the problem set defined in the right way, we might actually apply these tools to allocate resources to what we really need societally is to care for the most vulnerable.
Do you have concerns about the privacy of patient data as AI proliferates? And if so, what can be done to anticipate or mitigate potential issues?
Yeah, so this is an issue that occupies a great deal of my time. I am very concerned that when you introduce a new technology, you must have a plan to do so in a safe and effective manner. We have the FDA for drugs for a reason. Historically, information technology has not risen to the level of an FDA-style clinical trial for safety, because for the most part, if I bought Microsoft Excel to help me be a bit more efficient in calculating certain set of numbers, its accuracy or inaccuracy will not necessarily result in immediate harm. But if I introduce the concept that a magical box can answer questions and I rely on those answers to take action, a lot more is at stake. Privacy is one aspect of this. Today, generically speaking, if I uploaded my medical record to ChatGPT, generic open public version, it cannot unsee what I've given it. And then my medical records are part of the training model that then could be repurposed in whatever black box it operates under to decide what the next response to the questions will be. That is definitely no mojo, no good mojo, bad mojo. So what we need to figure out is how do we install a version of these technologies? So let me just make sure we understand what is the AI tech stack. At the foundation level, we have this box that is like a hungry animal eating up all of the data on the internet. And from that, it's running these neural networks to guess when asked the question, what is the question trying to seek an answer for? And then how can I best assemble all the words to answer it? That foundation model then has guardrails or some kind of capacity for fine-tuning. And in these two layers of the stack, the guardrails layer and the fine-tuning layer, there's a lot of opportunity for startups, for big companies, enterprise level, sort of startups that are, high promise, to take those foundation models and mold them to make sure in the issue of guardrails that we have a safe room where you can upload content that won't go back to the model for training, that will protect the intellectual property rights of the content that you're trying to understand, and have properties that are to some degree on the security side capable of not being misused. So, I could say, tell me the worst things about April, and I want to say mean things about her on the internet, and I could ask the LLM to go find out more about you and give me the worst things to say about you. That would be a horrible thing for society. So security, privacy, intellectual property, these are, kind of our ethical and moral compass of a nation that we want to make sure the technology is constrained in what it can do to kind of to put harm in our lives. So the fine tuning allows us to add more context and more data that may not be in the general model as they are, so that it can be smarter about questions we want answered that are maybe unique to healthcare. And the guardrails are going to be to make sure that the way information goes in is used and is exported meets a broader ethical framework.
Since in your last comment, you mentioned the FDA and the importance of guardrails, now putting on your hat as a former government official, what do you see as the future for AI regulation? Do you think a new federal agency will be needed? Will regulatory action or oversight for agencies such as HHS be sufficient?
Yeah, so this is, now I'm going to bias it because I'm pretending I'm still in the government. President Biden has not named a US CTO, so I have some liberty. Many of them are my friends. I reach out and connect on a regular basis. And so I have a little bit of liberty here to kind of say more about what I would be doing if I were in the role, because I'm actively trying to do those things because I think we desperately need it. A quick reminder, we have always had a scenario where emerging technologies of any sort have implications on sectors of the economy that are already regulated. So my cousin Rohit runs the Consumer Financial Protection Bureau. He's trying to make sure that mortgage products and banking products are safe and effective. The FDA, we talked about. The Federal Trade Commission has a mission statement here. The Consumer Protection for Individual Products, Product Safety Commission. These are all examples where agencies are already the cops on the beat to make sure that parts of the economy work well. When a new technology shows up, it's difficult in government to have perfect expertise on the implications of that technology in each of these siloed domains. So in the Obama administration, my colleague, Dr. Holdren, the chief science officer, worked with our OMB director, Peter Orszag, to put in place a framework for how we can bring emerging technologies to the market in a safe and effective manner. And the answer was not new agency, Moses tablet-like definitive regulations in an area that's moving so fast. The answer is the answer that I would like to see us adopt here, which is that government with a lowercase g is us working together for the betterment of each other. And so it is more feasible for a multi-stakeholder body to include the AI companies, consumer advocates, in the healthcare sector, obviously patients, doctors, regulators, to sit around the room and say, okay, what are some of the key questions that we want to have answered? What are the sort of inventory of harms that we want to mitigate? And what are the steps we can take today to do more of the good stuff and less of the bad stuff? In other words, what if we wrote our own regulation? And how could we then make that collective action be enforceable under the existing rules on the books? That is where I think we land on trustworthy AI, that we understand that these questions of privacy, of security, of intellectual property rights, of harmed individuals that may be subject to these sorts of attacks, the hallucination risk as it relates to decision support. In context A, we can tolerate some hallucination. In context B, when it's mission critical and minutes matter on saving a life, we don't want to put the healthcare system at risk by over-relying on the recommendations of a black box. So when we understand these examples of specific harms, that we might have a framework that the stakeholders across the sector say, here's what that means, here's what you have to do. If you're a hospital, don't you buy an AI product unless it meets the following 3 conditions, and that they've committed to do the following 5 things. If you are a model developer, here's how you sort of think about your own before you ship a product. Have you red teamed the software to see whether there's evidence of bias that you're propagating? Whether you did it knowingly or unknowingly, is it there? Is that the net effect of the technology? And for regulators, what does it mean to audit? If I'm going to audit your business, I want to make sure that the work you're doing is going to not create consumer harm. Like my cousin at the Consumer Protection Bureau said, I need to make sure that you don't discriminate in mortgages. Well, I don't know if he's going to be an expert in AI. Rohit's pretty smart. I think his organization will do better than most. But I think what he can do is say, hey, whether it's AI or SHMAI, if you if I see evidence of discrimination in the audit, then you're going to be held accountable. So how do you appropriately audit the technology so that it doesn't overkill its use for the good, but it allows us to have some North Star so we can all agree, here's what we're going to do to make sure that this gets introduced to our patients and to our clinicians in a safe and responsible manner. So it's a long-ended answer to your question, which started with the idea of, do we need a new agency or new laws? And my answer was neither. We need to work in this multi-stakeholder fashion in the immediate term, like weeks and months from now, while we sort out what happens in the real world to see if there are spikes of harm missed by these voluntary frameworks for which we need more action.
Well, with that, thank you again, Anish. I've certainly learned a lot. Thank you for taking the time to join us today and share your insights and expertise on AI in healthcare.
Thanks for having me, April.
We're very pleased to welcome our next speaker, Dr. William Weeks. Dr. Weeks is a physician economist leading Microsoft's AI for Health program. Founded in 2020, AI for Health is committed to improving the health of the world's population. Dr. Weeks and his colleagues focus on three broad areas: population health, imaging analytics, and the use of large language models in healthcare. Dr. Weeks has published over 200 peer-reviewed articles examining economic and business aspects of healthcare services.
So, Dr. Weeks, to kick us off, artificial intelligence is fast emerging as an essential healthcare tool, but it is still new to many. Can you begin by giving our audience a basic definition of AI?
Yeah, so AI is artificial intelligence, and it's kind of a subset of intelligence, right, which is itself a bit hard to define. But generally, when we think about it, what is intelligence? It's the capacity to learn and adapt to new situations. So you experience something, humans do this, right? You experience something, we learn, not to touch the burner, and then we adapt by not touching the burner when we see it's on. So that's kind of learning, and that's intelligence, and other animals do this as well. Artificial intelligence is non-human intelligence application. So it's allowing computers and machines to do the same thing, to take a data set, to look at some information, and to learn from it and adapt the algorithm so it kind of learns better and can predict better than when it initially started.
Thanks for that overview. So I mentioned at the beginning about the potential use of AI in advancing health equity. Can you provide some use cases of how AI is being used successfully to improve clinical care and drive better patient outcomes? And can you discuss a specific program where you are seeing measurable results?
Sure. So there are several. So I think when we think about AI itself has multiple subsets. There's kind of machine learning, which is the basics that what I just described. And then I think what's captured the attention of the world is the large language models, the generative AI, where you can put in something and get this fabulous response or a paragraph written for you and things like that, which is essentially using words, prediction models to predict the next best word. So it's still a prediction model, but it's just based on words. I think just because it's been captured more recently and in the media, people think, oh, this is this brand new thing. But AI kind of surrounds us constantly. When you order something from Amazon, they say, hey, how would you like this? And you say, I would like that. That's AI being applied to you and just tracking your patterns of utilization and saying that you have similar interests to someone like you, and they also ordered this. And AI is integrated into our cars and our phones and all sorts of intriguing stuff. In healthcare, it's I think most commonly used in radiology and imaging, where the AI models can help focus radiologists' attention to this area, and so they don't have to look at the entire 400 slices that they might be looking at, but indeed can focus on the kind of highest problematic area, and possibly even avoid seeing a lot of normals. I mean, one of the challenges that providers have is that most of the work that we do is treating patients who are normal, who don't really have many problems, or certainly don't have very complex problems. So by allowing providers to kind of focus on where the area of need is, it kind of tremendously has the potential to accelerate their productivity and their output. Projects that we've used that have been in imaging, for instance, are kind of interesting and impactful are a couple. One is we've imaged skin in Brazil and Mexico to identify leprosy lesions. Leprosy is it's an infectious disease. It's treatable if you catch it early. If you don't catch it early, it can lead to multiple amputations and loss of limbs and digits and stuff like that. And so by simply using algorithms that can identify this looks like leprosy and this skin lesion does not look like leprosy, the key thing you can do then is not necessarily diagnose the patient, but direct the patients who need the care to these scarce resources like providers and dermatologists who could actually treat the leprosy.
So moving right along, so while AI has great potential in promoting health equity, there are also concerns related to its use in healthcare and ensuring that AI initiatives do not continue to perpetuate the same inequities already faced by marginalized and minoritized patients and communities. What are some of the concerns about AI solutions when applied to diverse patient populations?
So the concerns are the identical ones that exist in medicine now, to be honest with you. When we look at kind of what's the best treatment pathway for someone over time, the reality is that the vast majority of studies that have been done to determine that best pathway have been done on people who look a lot like me. And so it's not a diverse population that has been tested. So that if we put in data that is only about people who look like me, there is this opportunity for continued bias to occur. Now, I think what particularly the large language models can do is by looking into electronic medical records, you can use large language models, which pick up again more of the text, to determine which patients of a diverse nature might have a particular disease, and to even track their probability in this kind of pseudo-experimental way to see for a patient with these particular characteristics and potentially demographics, what is the best treatment outcome for them? So then you get to personalized and individualized healthcare by kind of exploiting these. I do think, and I like to bring this up because I think it's really important. When we think about AI and people get concerned about the AI modeling and stuff like that, I think it's always important to say, compared to what, right? Because I think, again, to highlight, our current healthcare system is pretty inequitable and pretty biased in its inputs. And what we determine, who gets access to care, how often they get access to care, and what treatments are kind of recommended. So there's inherent bias in the system. And I think with AI algorithms, you can run multiple AI algorithms over one another and have one of those kind of external ones examined for bias in a system, which is kind of incredible and doesn't happen right now. So I think there's bias. I think there's also, we often will want the AI output to be perfect or near perfect, or we'll say, oh, we're going to compare this to the top 3, cardiac surgeons in the world, and look at, compare the output of the algorithm to that. That's, I think, an unfair comparison, because, the statistical percentage of people who get to actually encounter the top 3 cardiac surgeons in the world is 0. Most people don't get absolute world-class care. What they get is average care. And what we know from Institute of Medicine reports, and even a recent paper that came out just a few weeks ago in the BMJ, is that there's been, medical error is a non-insubstantial contributor to bad outcomes in patients. So we want to have the AI algorithms, I think, be better than average, even be in the 70th or 80th percentile. And if we do that, my sense is that we can close the quality gap, which if you're in healthcare, you know this, right? You know that the quality of care you get will vary hugely based on which door you open in a clinic. of doctors who are employed by the same people, who may even have the same kind of recommendations going on to suggest the next best steps of care. So there's quality gap there, so we can close that quality gap, dramatically improve care for that bottom 70 or 80%, while also, I think, decreasing the timing of the reality that we know in medicine, which is, we prove something convincingly with randomized controlled trials, and a mere 17 years later, it's put into practice, right? We can close that substantially because these algorithms can identify what is best practice recently, right, with a recent update, which I think can inform providers in their ongoing treatment of patients.
So just to expand on that, can you describe some of the issues related to privacy of patient data as AI proliferates? Also, what can be done to mitigate potential disadvantages and pitfalls in AI?
So from a privacy standpoint, I think it's the same thing that exists right now. Patients should be able to opt in or opt out of having their data used in an algorithm. Just as, for instance, at Dartmouth, we did for years, that we've studied Medicare data sets, and patients in Medicare have the option of opting out, having their data not included in the data that gets to us. So I think it's up to the patient to do it. The interesting thing, I think, is that many patients, particularly those with rare diseases, want to contribute their data because they understand that the quality of care and the randomness of kind of the quality of care, it works to their detriment. So I think what we have to do is we have to be informative. We have to tell people that your data are going to be used for this purpose or that purpose, and then be fair in the distribution of the information as well, right? So not only the wealthy countries or the wealthy people get access to that kind of stuff. What was your second part of your question around after privacy?
What can be done to mitigate potential disadvantages and pitfalls in AI?
So what can be done to mitigate the potential downfalls in AI, I think, are, you have guidelines, or you have guardrails on this. It's not, you don't generate an AI model and then put it out for the world to use without testing it repeatedly. So just like with any medical device, you want to develop it, test it. The nice thing about the AI models is compared to a retrospective analysis or even a randomized controlled trial is that you can test your model on some data, on the test data, and then hold out other model for validation. So you can then test the model, see if it actually works in real time and not kind of as a follow-up, which is a real advantage, I think, for these models. So we can test, we can put in guardrails, we can have ethics around the use of AI. For instance, Microsoft, who has been involved in AI for 3 decades, I think, has these committees, as I'm sure all the other large companies do, to kind of understand what the ramifications of AI are and to go through actual reviews if there are new uses of AI being proposed. So there's that part. There's the informed consent kind of part, the privacy issue that, yeah, this is AI algorithm. And I think that the key thing is probably to make sure that, the fear that providers have is that, oh, this is going to replace me. It's never going to replace you. It's going to be a tool, just like a stethoscope was a new technology tool. And an MRI was a new technology tool. It doesn't replace the provider. It enhances their performance and their ability to achieve the quadruple aim. So as long as I think we think of it like that, we also will have human opportunities to correct and to think about with the provider and the patient in a kind of a shared decision, kind of a co-development of health framework. How can I use this information to maximize my health and so make sure that the AI? I mean, no one I think is suggesting, oh, we'll just have AI algorithm run and just April Joy's rest of her medical career will just be managed by that. I don't think anyone's kind of suggesting.
Thanks, Dr. Weeks. So you've mentioned a few times already that AI can potentially benefit not only patients, but also the healthcare workforce itself. So we've heard that AI has the potential of reducing clinician burnout. Can you further elaborate on some of the key tasks that can be supported by AI?
Sure. In particular, these large language models, I mean, they're very useful for kind of the back-end operations that drive providers crazy and suck up a bunch of their time. So you can just tell ChatGPT, write a letter that justifies Mrs. Smith's use of this particular medication for the insurance company, and it will do it. And you can say, and include several citations, and it will do it, and they will be accurate. And so instead of a provider doing this, it can just be done. So the back end operations, particularly if we think about like ambient intelligence that can occur in the workplace, where now we have some, a computer on the wall that can actually listen to the conversation, generate SOAP notes from the conversation, take orders. So if I'm talking to you, it can say, hey, let's get a CBC on April Joy or something like that. It will take a notification of that. It could generate a potential differential diagnosis and even include the billing codes, right? All of which normally is done kind of after the event, when doctors who are imperfect and providers who are imperfect forget some of the stuff that was said, and can occur in a setting where there can be multiple people in the room. And the ambient intelligence can kind of pick that up. So all of that effort that usually kind of, frankly, interrupts the patient-provider encounter can be outsourced, essentially, so that the patient and provider can have a nice discussion and actually get to the issues that matter. And I always get around that, half the time as a provider, you're sitting there looking at your computer and typing stuff in as your patient is kind of bleeding to death over in the corner because you're not really paying attention to them. Here we can go back to the reality of looking someone in the eyes, talking to them, seeing what matters. I think, and then having all of that captured with all of that back end stuff kind of understood and put into a reasonable framework that prevents things like what we get now with EHRs, which is just copy and paste, where if you make an error in an EHR, it will get perpetuated because everyone copies and pastes and uses the same thing and doesn't necessarily read the whole note. So it kind of eliminates some of the bad stuff, can eliminate the misdiagnostic stuff, and really kind of encourage the original desire of most people who go into healthcare, which is to have a conversation with a patient and help.
And lastly, is there anything you would like to add to help our audience better understand this technology?
I guess what I would add is that every new technology people come out is going to get a little extreme. It's either going to save the world or kill us all. And I think in between is kind of where this and most technologies will lead us. It will be imperfect. But again, I think a really important thing to understand is the current system is very imperfect. So we can't let the perfect be the enemy of what in some cases the very, very good. Particularly, I think, when we're looking at the disenfranchised who have challenges even getting access to care, and in lower and middle income countries, there are 4 billion people in the world who kind of have very limited access to care. So if we can give very, very good care, but perhaps not perfect care, to half of the world's population, or at least drive them into the direction of having that care, then that's doing quite a bit. And the marginal improvements will be minimal, I think, going forward. So that's the reality. I think we got to think about what's the comparison and what's fair. We have to understand that there are a lot of people in the world, and I think some of the clients that you guys deal with are quite disenfranchised, right? They don't have access to care, and this can really extend care access, particularly if we're using things like remote like Teams or Zoom or something like that to provide some of the care, where this ambient intelligence can also be part of these kinds of encounters. So I think I would be very, people say that they're cautiously optimistic. I'm incredibly optimistic. I'm incautiously optimistic, I guess, about this technology, because I think it really has the potential to achieve that quadruple aim and address the so-called, the healthcare workforce crisis that we have. I mean, I think when we look at other industries which have been using these types of technologies for a number of years, like finance and retail and others, the productivity has increased considerably. And we haven't seen that in healthcare. While we have great technologies like MRIs and SPECT scans and all the cool stuff, putting pig kidneys into humans, right? That just happened last week. All this wonderful technology. Its impact on the population is minimal. That helps the people can afford it and can get it, and they get this exceptional care. But the rest of the people are kind of left behind. And I think these technologies can really even that up, so that the workforce can be tremendously productivity can tremendously increase. I mean, 30 years ago we were studying physician panels and sizes, and they're not dramatically different than they were then. Now, right? So panel size hasn't really increased. And what we've done is we've added a bunch of mid-levels who also have their own panels that are about the same size. And we've done things like to adapt to an electronic health record. Unless you're a primary care physician, all the specialists now have scribes running around, following them to jot stuff down to then later put into the electronic health record. So none of that would be kind of technological efficiencies for the healthcare field. In fact, it's kind of inefficiencies. You're supposed to substitute labor or technology for labor. If the technology goes up, the labor would go down. And what we're seeing is, in response to the technology, the labor has actually kind of increased. So I think this has the opportunity, that the large language models in particular, and the use of AI, again, to use providers much more efficiently, has the opportunity to actually get that technological productivity burst that we just haven't seen in healthcare, but again, we've seen in every other industry that's used these kind of technologies.
Well, thank you again, Dr. Weeks, for taking the time to speak with our audience and also share your expertise. We truly appreciate Microsoft's commitment to developing the potential of AI in addressing health equity and improving healthcare across the globe.
My pleasure. It's been delightful chatting. Thanks.
Next, we will hear from Dr. Roland Iling, the Director and Chief Medical Officer, International Public Sector for Amazon Web Services. Dr. Iling is a physician, academic, and healthcare leader with a passion for transformation, growth, and excellence. Dr. Illing is an honorary associate professor at the University College London, a member of the Royal College of Surgeons of England, and a member of the WHO's roster of experts for digital health and the European AI Alliance.
So as you know, Dr. Illing, our audience consists of providers and staff of federally qualified health centers across the United States. They care for underserved patients who often must manage complex medical conditions and experience difficulty with many of the social determinants of health. Telehealth certainly brought digital medicine to the forefront during the pandemic, though many of us are still in the early stages of understanding AI's potential for improving patient care. We would like to help everyone watching this broadcast better understand this emerging technology. And so now to my questions. To start us off, Dr. Illing, AI is well established in various medical specialties. How do you view AI's adoption in primary care, and specifically by health centers?
I think the adoption of AI in healthcare is a very interesting discussion point all around. It's top of mind for a lot of people, especially with the latest iteration of AI being generative AI coming out and capturing everybody's attention. And I think the promise that AI holds, both in primary care and more broadly across healthcare, is absolutely imperative to get right. I think we're seeing an adoption of AI services in the clinic today in a fairly niche group of subspecialties. In particular, specialties like radiology have been in the forefront of adopting some of this technology. But in fact, we're seeing now AI come out not just with very specific answers to questions around imaging, is there a lump or isn't there a lump? We're getting into more specific questions around patient pathways and stratifying patients to understand their specific needs. And when it comes into not necessarily clinical decision support, but actually operational support, I think that's where we're going to see the fastest adoption of AI in medicine more broadly. So, for instance, how can we make sure patients arrive at the clinic in time? How can we optimize workflows? I think they will actually be the questions which will be answered first before the how, is this patient sick or not?
How do you see AI as a path to greater health equity? Can you provide some examples of its use in underserved and vulnerable patient populations?
Absolutely. We see AI as a critical path to address factors affecting health equity. In fact, we launched a health equity initiative at AWS about a year and a half ago, where we were giving away $40 million over 3 years to address programs that affect health equity. And we've already given away $14 million of that 40 in the first year to 90 programs around the world. We also launched an AI accelerator addressing health equity that was launched at the end of last year. And we announced 10 startups that were chosen as part of this program. And there's some really interesting AI startups that have come to light. So, for instance, Samaritan is an AI company based in Seattle, and it is a platform that empowers people without a home to reach housing and health goals. And through their solution, they can connect to those without a physical home and healthcare and community support. And we're supporting patients around the world with TB through an organization called Cure AI. And so Cure AI developed an algorithm that can screen chest X-rays at scale on the cloud using cloud computing. And they're able to screen for TB and then push the results of whether there is a high preponderance or low preponderance of TB back to the care providers at the point of need. So in short, I think AI will democratize access to healthcare. It'll both surface patient groups who may be underserved, but also provide expertise to areas that may not have enough care providers to really provide best-in-class care for their patients.
From your perspective, what are some of the main benefits to healthcare consumers given the emergence of AI?
Well, I think that benefits to the consumers of this product is that they hopefully will be able to, in the future, receive more personalized care. Always is to make sure that the right treatment can be delivered at the right time to the right person. And the more information we can get about individuals will mean that that treatment can be tailored more effectively. For instance, we're working with Genomics England in the UK to work around personalized medicine. So they have a genomics medicine service, which is a national program. And they can take genomic information, clinical information, pathology information, and then integrate that data using artificial intelligence to deliver very personalized recommendations to individuals. And where we see these national biobanking programs taking place, and we're very delighted to support global biobanks around the world, for instance, the Genomics Institute of Singapore, Melbourne Genomics Institute, Genomics England, UK Biobank, CancerJourney in Canada. Many national programs are building out these national biobanks to look across their populations to work out the most effective treatments based upon their population's health. And so I think where we're seeing impact on the consumer, I think that's the most important thing. And the pathways can be managed for the providers can be optimized, but at the end of the day, we really need to see benefits for the patients themselves. And I think that will also spark the patient's willingness to engage in data sharing, because that's a key attribute where it comes to developing new kinds of algorithms and treatments on top.
Now, what are some of the most important issues regarding privacy and security about which we should be aware?
So privacy and security is absolutely job zero. And I think there's a lot of education that's required for those people who are both in health systems more broadly, but around digital security, cyber security, and also what does not happen when using AI. I think it's really important to understand that if you're using a cloud-based application, that those clouds that are being used don't have access to identifiable data. They are the buckets on which that data is transported and analyzed, but the data itself is accessed only by the designated authorities that use it to develop those applications. And so they have to be trusted. So I think privacy and security has to be paramount. And by leveraging the cloud, we're seeing a big reason why people are now moving to cloud computing is because it is more secure than on-premises. With all of the safeguards around it, the data and the usage of that data can be tracked in a very, very granular way. So I think educating care providers, CEOs, and also government officials that the power that cloud can bring to democratize access to this AI capability is absolutely key. And we're seeing that happen around the world, where it's becoming not only cloud first, but mandatory cloud introduction of these kind of technologies.
Now, Dr. Illing, can you tell us a bit about your mission as a leader of Amazon Web Services?
So Amazon Web Services, AWS, has a healthcare mission that we've been investing heavily in the last 4 years, both into subject matter experts and into the technology which underpins a lot of the applications which are now coming onto the market. So we have a mission, and our mission is to enable access and delivery of person-centered care to improve outcomes at a lower cost by accelerating the digitization and utilization of healthcare data. And we do that by making the most flexible, secure, and available platform to deliver all of this next generation of solutions. And we're bringing out microservices, which can be put together to really handle very specific data types coming from healthcare. For instance, we have a FHIR server. So HealthLake is a FHIR server that can ingest text data and then store it with appropriate tagging, but then secondary use. Likewise, we have health imaging, AWS Health Imaging, which is a service which can ingest imaging data and again can store it appropriately and stream it to endpoints. And so we expect the next generation of solutions to be built out using this capability. And we're very fortunate in that we're partnering with organizations, sort of large global tech organizations like GE Healthcare, Philips, Illumina in the space of genomics, and of course the largest electronic medical record vendors.
Well, it's quite impressive. Is there anything I did not ask on which you would like to comment?
Well, I think, as I said at the start, I think one of the really interesting areas that's just come around is generative AI. And it's the talk of the town that everyone will be doing generative AI. And AWS's view on generative AI is very much that we would like to democratize access to foundation models in much the same way that using the cloud, end providers and patients themselves can have access to virtually unlimited computing power and storage of their data on the cloud accessible through the internet. We want to make sure that our end users have access to all of the top foundation models available, because we understand that in the future, there won't just be one foundation model to rule them all. There'll actually be hundreds, if not thousands, of foundation models, which are looking at very specific data types on which new models will want to be bought. And so we have a very strong AI and machine learning capability. We have hundreds of thousands of customers using AI on AWS already. Over 90% of deep learning actually in the cloud happens on AWS. And so we've brought out a specific service called Bedrock, which will allow users to use an API, a very easy user interface, to access these foundation models on demand. And the key is to securely tailor them, because a problem at the moment is that many foundation models are, well, whether they're open or closed doesn't matter, but you have to give your information to the foundation model in order to get meaningful results from it. So we've been looking at how we can develop Bedrock so that end users don't have to share their own data with the model in order to extract meaning. They can take the model, match it to their data in a secure environment, gain insights that only they see, but then they put the model back into the pool untouched. So I think doing that kind of governance and that kind of responsible use of generative AI is absolutely critical and has to be seen by the general public in order to be trusted that their data is going to be safe.
Well, that was very helpful. Thank you very much, Dr. Illing. We really appreciate you sharing your expertise and insights with us on this broadcast.
Perfect. It was an absolute pleasure. Thank you for inviting me.
Thank you again to our speakers, subject matter experts, and to all of you joining our broadcast today. We look forward to hearing your feedback, and we'll see you next time.